Good evening, everyone, and welcome to the second episode of the webinar series of the Society of Fetal Medicine Northeast chapter. And our webinar series is mainly dedicated to discussing just one group of pathology or a single pathology in every webinar, inviting the best of national faculty as well as encouraging our local members to present their cases. So today our topic of discussion is fetal limb anomalies, skeletal dysplasia and beyond. And we are indeed very honored to have three very expert faculty: Professor Ashok Khurana, who is the Mentor Emeritus of SFM, past President Dr. Bimal Sahani sir, who is an excellent teacher, and President Dr. Mohit Bir Kumar Shah. So without wasting much time, I would now like to invite our President of the Northeast chapter, Dr. Apurva Bhatta sir, to welcome the delegates and faculty and say a few words. Over to you, sir.
Thank you, Zina. Good evening, everybody. So after we took over our charge, the new team, we are looking forward to hosting our second webinar, this second episode of this webinar today on 2nd of August. And the topic is, as Zina already said, the limb abnormalities, skeletal dysplasias and beyond. So we are indeed grateful to our central SFM for all guidance and support really received in this time. We are truly grateful to our mentors, Professor Khurana sir, Dr. Bimal Sahani sir, and President of SFM, Dr. Mohit Birsa, for accepting our invitation to be a part of this program as expert faculty. Our sincere apologies if because of some lack of the official mail informing the central SFM was rather late. I'd like to thank Mr. Bisal Mittal for organizing everything and all the trade partners who are associated for this webinar. Looking forward to have more webinars in the coming days. We are having outreach program also. We have finished already 2 outreach program and 3rd is on the year in this month. Thank you. So I'd like to ask Zina to start the program. Please invite the speakers.
Thank you so much, sir. So today our first speaker is Dr. Runmoni Deka. She's the professor and head Department of Anatomy and also the Dean of Research in All India Institute of Medical Science, Guwahati. And her main area of interest is human genetics and immunogenetics and transplant immunology. So today she'll speak on the development of the skeletal system, the basics of embryology and genetics. So Dr. Runmoni, please share your screen.
Thank you, Gina, for the kind introduction. I'll be sharing my screen now. Can you see my screen? Can you see my screen?
No, ma'am. Go to Zoom, click on green button at the bottom.
Did it.
And just click on that slide which you want to share.
Yeah.
At that window.
It has come. It has come.
Yeah.
Yeah, yes.
Now start.
Is it visible now?
Yeah. Yes. It is, Runmoni ba. Yeah.
Yeah.
Okay.
It's shared? Yeah.
Yes.
So first of all, I thank the Society of Fetal Medicine for giving me this opportunity to be here and to be a speaker in this forum. I'm really honored to be amongst all the experts and stalwarts here. Can you hear me?
Yes,
yeah, we can hear you. Please continue. Please continue. Yeah.
Your screen went off, Ronmoni.
She's here, but I don't know. She went on mute only.
I'm just calling her. Just a moment.
Her network is unstable, I think.
Should I call her? Okay.
It's
It's
come
come.
on. Yes.
Yeah.
Perfect. We don't hear you though. Ronmoni, we see your slide, but you're muted.
Gina, call her.
I'm calling her, but she's not picking up the phone. I'll just call her once more. Yeah.
Yes.
I'll just call her.
Muted, and that's why we've lost her again.
Otherwise, we could do Gina's talk first, and somebody else could take.
She has
Ronmoni.
left. She has left.
Yeah. So if someone else can guide Dr. Ronmoni, then Dr. Gina can do her presentation first.
Okay, sir.
Yeah.
All right.
But you'll have to depute somebody to guide her for and see whether she's able to.
I'll tell Zoe. Yeah, call her in another room. Just a moment. Yeah.
Yes.
It good. Is my screen visible, sir?
Yes, it's perfect, and we can see you well, we
Okay.
can hear you well, and we can see full
Okay,
screen.
thank you.
Yeah.
Good evening, everyone, and thank you for joining. So it's indeed an honor to be presenting in this very prestigious platform. So as per Ashok Khurana sir's direction, I'm presenting this talk, Why Missing Limbs Are Missed on Antenatal Ultrasound. So we know that the incidence of limb abnormalities is 6 in 10,000 live births, with upper limbs being more commonly affected than the lower limb, and they are more unilateral than bilateral, and the right side is affected more than the left side. So the types of limb anomalies may be malformations, deformations, or disruptions, and the nature of the abnormality may be isolated, syndromic, malformation syndrome, or a sequence. Now, I will basically talk on the imaging because Dr. Runmoni was supposed to talk on the embryology and the genetics. So ultrasound is now one of the main imaging modalities for detecting limb abnormalities in the fetus, and it has been practiced since the 1980s. But various papers have said that, the detection rate of limb abnormalities is quite low. In 1991, Levi's et al. Found that it was 23.6. 1992, it was seen to be 48% for multiple anomalies, but 15% for isolated. In 1999, the Eurofitter study showed that the overall detection rate for anomalies is 61%, but the detection rate for limb anomalies was very less, that is only around 18%. And in 2013 as well, Gray et al. Found that though 31% of upper extremity anomalies were detected prenatally, however, only 18% were correctly diagnosed. So it was also seen that the detection of proximal limb reduction defects is better than the detection of hand or finger limb reduction defects, which is only 0 to 8%. So in 2005, the EuroCat study of almost over 4,000 fetuses with different anomalies reported that the prenatal detection rate of both upper and lower limb reduction was only 34%. And in a more recent study in 2010, there was a higher prenatal detection rate for limb reduction defects with associated malformations, which was around 49%, compared to the isolated ones, which was only 25%. So why are limb anomalies and missing limbs missed on a prenatal ultrasound? And how early can we start seeing the limbs and make a diagnosis? And what is the ideal time for screening? So it is seen that the skeletal system as well as the limb buds start to be sonographically visible from 7 weeks onwards. And between 7 and 11 weeks gestation, the embryo undergoes rapid development and growth, and organogenesis is largely complete by 10 weeks. So there is a series of development which takes place till 10 weeks. And we know that first, by 8 weeks, the limb buds are well seen. And then the fetus goes through its 9 weeks. The digits are not very well visible at around 9 weeks. But by 10 weeks, we see that when the fetus is around 30 to 35 mm of CRL, then we can identify the fingers also sometimes. And all the long bones are also identifiable by 10 weeks, and organogenesis is complete during this time. So there were several papers where it was said that, in 1992, there was a paper which identified fetal limb abnormalities using transvaginal ultrasonography as early as 9 weeks of gestation. And it is said that up to 90% of fetal limb structures, excluding fingers, can be seen on the first trimester ultrasound using a combined transabdominal and transvaginal approach. Now, in the early second trimester, the visualization of the skeletal is found to be much easier than for the other fetal systems, example, the cardiovascular system. And also the skeletal system is already completely developed around this time, unlike other structures, example, the central nervous system with the corpus callosum and the vermis. So what is the best gestational age for evaluating limbs on an antenatal ultrasound? So according to the current guidelines, the assessment of the fetal limbs should be performed in the late first trimester, that is beyond 12 weeks, and the early second trimester, that is between 18 to 24 weeks. So we've got several guidelines which have started with guidelines for the mid-trimester anomaly scan. So there was this ISWAG guidelines which came up in 2010. Then we had our own Society of Fetal Medicine guidelines in 2014. And then there was an updated guidelines in 2022 by ISWAG again. So they also have given us the 20 planes approach for the routine mid-trimester scan in order to see the fetal limbs much better. Then as the pyramid gets inverted and our machines are getting better, so guidelines have also come up for the performance of the first trimester fetal ultrasound scan, which first came out in 2013, but recently it has been updated in 2023 with much more guidelines which have been given to us. So what about the third trimester? Regarding the third trimester, the guidelines say that depending on the objectives of the third trimester scan, the anatomical evaluation may be undertaken, and if this is done, should target examination of the head, brain, heart, chest, abdomen, and the urinary system. And there is no mention that we should be looking at the fetal limbs. So it is seen that in the third trimester, the visualization of the fetal limbs is quite suboptimal and less reliable. And the main factors are that there is shadowing from the other fetal parts, fetal positioning, tightly closed hands, and there is also a decrease in the amount of amniotic fluid relative to the fetal size. So 3D ultrasound does have a role because sometimes it gives a better understanding of the fetal anomaly for the parents and helps in better counseling. But many a time, the 2D ultrasound suffices, and 3D can help to confirm the anomalies detected by the conventional ultrasound, but it does have its limitations because they face the same difficulties and restrictions that affect the 2D imaging in general. And these include the unfavorable maternal body habitus, decreased amniotic fluid, and advanced gestational age. So first we come to the 11 to 14 week scan, and what do the guidelines say? So we have two levels of screening according to the ISWAG guidelines. There is a checklist for minimum requirements for a basic structural survey at 11 to 14 weeks gestation. And there is a more advanced level of best practice for comprehensive details examination. So this is the checklist. And in the minimum requirements, regarding the extremities, it is said that we have to visualize the 4 limbs, each with the 3 segments. And in the updated guidelines, in the more advanced guidelines, it is said that we have to look at these upper limbs and the lower limbs with the 3 segments, but we also have to look at the movements. But there is no mention about evaluating fingers and toes. So in the updated guidelines from ISWAG in 2023, they recommend that we have to look at the femur length, and it is measured in the long axis, and the calipers are placed at either end of the ossified diaphysis, which is clearly visible. So, and for the limbs, we have to look at the presence of the 3 segments of both the upper and the lower limbs, and presence and normal orientation of the 2 hands and the feet should be noted. So these are the pictures that we have to give during our report. And we have to try and give a coronal view of the bilateral lower limbs with a clear visualization of the 3 segments, that is the upper legs, the lower legs, and the feet, and an axial view of the bilateral upper limbs with clear visualization of the 3 segments, that is the upper arms, lower arms, and the hands. And the first trimester fetus often presents with open hands, which may facilitate assessment of the hands and the digits. So in the 11 to 14 week scan, we have to look at the presence of the limbs, the movements, the side to side, the alignment. And it is seen that fetal limb movements are detectable from 9 weeks on. Just a moment, the video is not working. Just a moment. I don't know, the videos are not working. Should I remove this? Okay, yeah, I removed the laser pointer. So it is seen that fetal limb movements are detectable from 9 weeks on, and more refined limb movements begin after 11 to 12 weeks. And both the upper limbs are often found in front of the fetal thorax or face in a semi-flected position, and the lower limbs are generally flexed at the hip at this gestation. So next we have to document the 2 lower limbs, each with the 3 segments, and we have to see the feet with the normal orientation as in these images. Then we have to try and measure the femur length. Now the fingers are relatively easy to assess in the first trimester as the number and position, including the thumb, because they frequently lie in the same ultrasound plane. Now it is also seen that there is a tendency of the ankles to have an inward position, and this may result in an overdiagnosis of clubfoot in the first trimester, but we always have to follow up after 16 weeks or in the second trimester anomaly scan. So while we are looking at the fetal limbs during the 11 to 14 week scan, we see that an abnormal nuchal translucency may also accompany major skeletal abnormalities. So this was a case which showed an increased NT, and there was meromelia. There was amelia, that is the absence of the entire lower limb on one side, and there was a partial absence of the lower limb on the other side, which is known as meromelia. So this is the same case. This was diagnosed at 11 weeks. And an amniocentesis was done, and this was found to be 16p deletion, but I somehow misplaced the report somewhere. The fetal limbs, that is the upper limbs, were normal. So this is the importance of trying to look at all the 4 limbs and all the 3 segments so that we can document these abnormalities much better. So this was the 3D of the same. So this was the abortus, the picture of the abortus showing the ultrasound findings. So this was another case. So amniotic band syndrome is one of the most common cause of limb transverse reduction anomalies. And so this was another case which showed this absence of the distal part of the lower leg. And this is the amniotic band, which was causing the same. So there was just a stump in the right lower limb which was completely absent, and the left lower limb was completely absent and the right lower limb was only partially absent. So this was the 3D of the same case. Case 3 showing amelia and meromelia, I lost this on follow-up, but this was also, it showed the similar findings. And these were all diagnosed at, 11 weeks to 12 weeks. The upper limbs were normal. So sometimes, though we do see the fingers quite well during first trimester screening, and though it is not there in the guidelines, and we can detect polydactyly sometimes. So this was a case of a Meckel-Gruber syndrome, which had polydactyly, and on looking at the kidneys, we saw this enlarged cystic kidneys as well as an occipital encephalocele. So there are several other papers which also have, talked about the importance of limb examination during the first trimester. And a number of limb abnormalities have now been diagnosed in the first trimester, including amelia, radial aplasia, the clubfoot, sirenomelia, and phocomelia. However, these are very just case reports, and there are not too many case series reported here. So from the first trimester, we now go to the mid-trimester evaluation. So according to the ISWOG guidelines regarding the limb and the extremities, it is recommended that the presence of all 4 extremities should be documented, the presence of all long bones and their symmetry, length, shape, alignment, position, and the movement should be assessed. Counting of fingers or toes is not required as part of the routine mid-trimester scan. And the measurement of just one femur is usually sufficient unless there is a suspicion of an abnormality. So these have been highlighted as good practice points. So they've given this checklist, and in the skeletal system, we just have to look at the spine and then document that the arms and the hands are present and the joint position is normal, and also that the legs and the feet are present and the joint position is normal there. So the ISWOG basic training program has also given us the 2+20 plane approach, which is a combination of 2 overview sweeps and 20 planes to look at 7 anatomic areas. And regarding the limbs, they have said that we can look at the femur diaphysis length, the 3 bones of both legs, and the feet and the normal relationship, and also the 3 bones of both arms, both hands, and normal relationships to both the arms. So these are the points that we have to remember when we are looking at the lower limbs as well as the upper limbs. We have to see all the 3 segments in each limb. We have to look at the length of the bones, the mineralization, the symmetry, the shape, whether there is any bowing or fractures, the alignment between segments, the hands and the feet should also be separately imaged. And also it's very important to see the movement of the joints. So counting of fingers or toes is not required as a part of the routine mid-trimester scan guidelines. We have to take additional planes beyond the basic 2+20 plane in each anatomic area for more information. And whenever we see any suspected abnormality, we need to do a more detailed targeted study or a skeletal survey to look at the pathology. So regarding the lower limb, we have to document the femur diaphysis length. We look at the three segments and the three bones of the lower limbs, that is the femur, the tibia, fibula, and the distal feet. And we have to document both the feet and the relationship to the legs. So we have, so these are the images which show that, in order to measure the femur length, only both ends of the ossified metaphysis should be clearly visible. The longest axis of the ossified diaphysis is measured by calipers, and we should exclude the distal femoral epiphysis if visible. And while measuring the diaphysis, we should not measure the spurs which are seen on one end. So we have to document the three bones of both legs and the feet, both in coronal and sagittal. And if we see that the both feet are together, it usually indicates symmetry. So we also see that, when we are looking at the coronal view, the feet are seen en face, and we do not see the sole of the foot or the entire fingers. And this is very important. Also see the alignment and see both the legs together and all the three segments. Try and look at the tibia and the fibula. And also, if possible, we have to look at both the feet and try and look at the toes. So it is important to note that the foot and the leg are at right angles to each other, like the images in this left-hand side. But as we see on the images on the right-hand side, these are cases of clubfoot, where we see that on a coronal study, we can see all the toes, as well as the two bones of the leg in the same plane. And these feet are inwardly rotated. And a 3D sometimes helps us to visualize this abnormality better so that we can counsel the patients. So this was a case of bilateral clubfoot. So coming to the upper limb. So again, like in the lower limb, we have to see the three segments. That is the proximal humerus, the mid radius and the ulna, and the distal segment showing the hands. And we have to document both the hands and the relationship to the arms. And it is very important to document open hands. So even though the ISWOG guidelines do not say we have to measure the humerus, but we can, because sometimes a short humerus is an aneuploidy marker. Try to look at the radius and ulna. And if we see both the hands together, it also indicates symmetry. We also see that the hands are in a normally mildly flexed position, in a comfortable position, and this is not clenched fist. And it is always wise to look for the opening and the closing of hands. Counting of fingers is not mandatory as per the ISWOG guidelines. So we always have to try to give one image showing the open hand. And we should remember that the thumb might not always be seen in the same plane with the other fingers. So these are just a few cases showing of short femur in osteogenesis imperfecta, or it is also a marker for trisomy 21. And sometimes in case of fetal growth restriction also, we can see a short femur. And this is another case of a short tibia and fibula. So this was a case of a proximal focal femoral deficiency, where we see that both the femurs are very short, but the rest of the bones showed normal length. But this fetus also had a micrognathia. And finally, the couple decided to abort. So whenever we see very short limbs, we also have to look at the skull, the shape of the skull, do a proper skeletal survey. And this was a case of a thanatophoric dysplasia. And amniocentesis was done, which showed a mutation in the FGFR3 gene. So as per the ISWOG guidelines, the latest updated ones, it is very important to look at the joint movements, whether they are normal, because whenever we see fixed posturing, it is abnormal, and we consider it to be arthrogyphosis. So to conclude, fetal ultrasonography is the most important tool to provide prenatal diagnosis of fetal anomalies, and done correctly, it can detect most of the major fetal limb abnormalities, and I'm sure that our detection rate is going to get much higher. And we have to remember that in order not so that we do not miss the missing limbs or the various limb abnormalities, it is very important to do a sequential systemic approach to scanning the upper and the lower limbs. We have to follow the current guidelines and scan beyond them. Screen during the best gestational age for seeing the fetal limbs, that is during the late first trimester or in the early second trimester. Try and use high resolution machines. And I've already mentioned the optimal time. And whenever we do a comprehensive fetal examination, we should encompass all the three planes, the coronal, longitudinal, and the axial. We should examine both the right and the left limbs. And this is very crucial, considering that sometimes only one limb may be affected. Abdominal ultrasound is usually employed, but in cases of earlier trimesters, earlier weeks, we can use transvaginal assessments in order to see the anomalies better. And studies suggest that whenever we give more time to seeing the fetus and the limbs, it improves the diagnostic rate. And early prenatal diagnosis not only allows for counseling, but also provides an opportunity for decision making. So thank you so much for your patient hearing. Thank you so much. Stop sharing. So
That was an amazing presentation. It was truly, truly amazing, fantastic. And it's
thank
not
you.
just a collection of images, which were completely spectacular, but
Thank
an excellent treatise on the subject. And I can see that this is going to be one of our webinars on YouTube that's going to get the greatest hits in the next few weeks, because
Thank
this
you,
has been such an exhaustive explanation of how we do this. And I think the other thing that you really brought out is that when we have a webinar, I think all of us must learn from this, that it's not just like a lecture in which we vomit things out. You take every topic bit by bit, hand holding, almost mollycoddling, explaining each bit and making sure everybody takes these messages home. Or should I say, everybody takes these messages to work. And congratulations for a fantastic talk.
Thank you, sir.
I guess it is time to move on to our next talk.
So now we have Dr. Mohit Shah.
Lunmoni is not joining. Dr. Lunmoni will not
I
be.
don't know. She's not.
She is still trying to get a good.
I have joined.
Ah, she
great.
has. Wonderful.
So, Runmoni Ba, can
Gina,
you
I'm joined. Yeah.
please share your screen? Yeah.
Okay. Can you see my screen? Gina, is my screen visible?
It is
Yes.
visible now. You just have to make it a single slide.
Is my screen
It is
visible?
visible. It is visible, Runmoni Ba. You just, yeah, it's good now.
Okay. I'll continue.
Yeah.
Okay. So my talk should have preceded Gina's because this is the basic. Anyway, I'm really sorry for the technical glitch. Okay, so now to understand the development of the skeletal system, we have to know that the development takes place in various forms, and the early development is very important for us to go to the rest. So is determined. We are germ disk now. The cells from the epiblast migrates to the deeper layers in between the epiblast and the hypoblast, and then starts replacing the cells of the hypoblast. Some of the cells remain in between the epiblast and the hypoblast, forms the mesoderm. The one which has replaced the hypoblast becomes the endoderm, and those which remain in the epiblast finally form the ectoderm. This process of migration of these cells after one very important in the this period is that these three layers are the main layers from which we get all the structures of the body. The ectoderm, leading to the development of the nervous system, skin, hair; mesoderm, muscles, bones, cardiovascular system; and the endoderm, leading to the internal organs like digestive system, lungs, and other internal organs. So we shall be mainly concentrating on the muscles, bones, and cardiovascular system because of the its involvement in the limb development. So during this development, there is formation of another structure which is equally important, is the notochord. The notochord, the prenotochordal cells invaginating the primitive pit, now moves forward towards the precaudal plate. It forms the notochordal plate first, which there is a thickening in the hypoblast, which later on detaches from the hypoblast and then forms the definitive notochord. This serves as the basis for the axial skeleton. So the cranial end of this notochord forms first and the caudal end is added later on. So in the formation or development of the skeletal system, there are two types of methods. That is the endochondral ossification in forming the bones and intramembranous ossification, which leads to the formation of bones as well. These are most of the bones in the body, and these are just the membranous bones like flat bones, for example, the skull bones and the clavicle. Another important event occurring subsequent to gastrulation is neurulation, which leads to the formation of the neural tube from the ectoderm. Okay, the formation of the shaping of the and folding of the neural tube, the closure of the neural tube, formation of the neural crest cells, which are very important sources of extremely important structures, and finally the differentiations of various parts of the central nervous system. The embryonic period thus extends from the 3rd to the 8th week of development and leading to the development of these basic tissues. Now, induction of the neural plate is regulated by inactivation of the growth factor, that is BMP, bone morphogenic factor protein 4. In the cranial region, it is inactivated by noggin, caudin, and follistatin, which is secreted by the notochord and the precaudal mesoderm. Inactivation of BMP4 in the hindbrain and spinal cord region is affected by WNT3A and FGF, fibroblast growth factor. In the absence of these inactivations, the BMP4 causes ectoderm to become epidermis. In the absence of inactivation, BMP4 also causes mesoderm to ventralize to form the three different components, namely the paraxial mesoderm, intermediate mesoderm, and the lateral plate mesoderm. The paraxial mesoderm forms the somatomeres. The intermediate mesoderm forms the internal organs of the genitourinary system, and the lateral plate mesoderm, it forms the lateral body wall, also the limb buds, and the splanchnopleuric mesoderm, it forms the internal organs. So this list, I shall not be describing it in detail. This shows us the day's respective somite stage, the length of the embryo, and the respective appearance of the various structures of the body. We shall be concentrating on this time of the development. So the derivatives of the somites are the myotomes, sclerotomes and dermatomes, leading to development of muscle tissues, cartilage and bones, and subcutaneous tissue of the skin, which are all supporting tissues of the body. Now, these signals for the somatic differentiation are derived from the surrounding structures, namely the notochord which is formed, the neural tube which is forming, and also the epidermide, the dorsomedial portion of the somite to form the apexial musculature, and the BMP4 FGFs from the lateral plate mesoderm. Lateral plate mesoderm is in the lateral side. And WNTs from the epidermis, this cause dorsolateral portion to form the limb buds, body wall structures. The caudal lateral folding of the embryo results because of development of so many structures at the same time, and this is controlled by the homeobox genes, namely HOX A, B, C, and D. The 3' end mainly controls the development of the cranial structures, and the 5' end regulates the differentiation of the posterior structures. Now, because of these developments, the flat embryonic disc, which comprised of all the 3 layers, now there is a cephalocaudal folding as well as transverse folding of the embryo. The cephalocaudal folding brings about the shape of the embryo to this one from this flat plate, and the side-to-side folding brings about the round cylindrical body structure. So from the 4 weeks of development up to the 8 weeks, this time
She has lost her connection.
Am I audible?
Yes, ma'am.
Yes, Runoniba. Yes.
Okay. At the end of the 4th week of development, the limb buds become visible as outpocketings from the ventrolateral aspect of the body. This is the upper limb bud and the lower limb bud of this picture. Much of the initial growth and patterning of the limbs occur during these period of from 4 to 8 weeks. After 8 weeks, the limb elements just increase in size because by then they have formed the entire limb bud. Now this limb bud, it has got a mesenchymal core at the center, which is derived from the somatopleuric layer of lateral plate mesoderm, and this forms the bones and the connective tissues of the limb. This is covered by a layer of cubical epithelium or epiectoderm, which is known as the apical ectodermal ridge, this part. The apical ectodermal ridge is the main portion which induces and also gets in proceeds forward to form the entire limb. This ridge exerts an inductive influence on the adjacent mesenchyme, wherein there is an intervening region of active proliferation. So as the limb grows, the cells farther from the influence of AER begins to differentiate into cartilage, and in this manner, the development of the limb proceeds proximo-distally. So as it is growing, this area of proliferation also proceeds along with the AER region. To the posterior aspect of the AER region, there is another region known as the zone of polarizing activity. It is found in the base of the limb bud, posterior aspect of the base of the limb bud. Now, this zone of polarizing activity, it maintains the AER, okay, and its secondary responsibility is to ensure asymmetry in the limbs. Position of the AER is important as it marks the boundary between the dorsal and ventral limb ectoderm, and the ectoderm is able to exert dorsalizing and ventralizing influences over the mesenchymal core. As for example, it removes hair follicles from the palms and soles of the feet. Now, till now, the entire limb bud, the AER region, was just one curvature along the distal edge of the developing limb bud. The mesenchyme now condenses into plates, forming the cartilaginous models of the future digital bones. After a certain period of time, the AER breaks up and is maintained only over the tips of the developing digits. The interdigital spaces are then progressively sculpted by cellular apoptosis. Hence, we see that by the age of 8 weeks, the fetal limbs have developed in its form, having all the 3 segments, and further development only comprises of elongation and growth. Usually, the upper limb begins development the first week, with the lower limb often lagging 2 to 3 days behind. The limbs are very well differentiated by as 8 week completes. The molecular regulation is the important event which decides the positioning of the limbs along the craniocaudal axis in the flank region of the embryo, and this is regulated by the homeobox genes expressed along this axis. Now, in case there is any misexpression, then the position of these limbs will be abnormal. So once the positioning along the craniocaudal axis is determined, the limb outgrowth, which is initiated by the FGF10 secreted by the lateral plate mesoderm cells. Once outgrowth is initiated, the bone morphogenic proteins, they are expressed in the ventral ectoderm. This induce formation of the AER by signaling through the homeobox MSH2. So expression of this leads to the further progression of the limb towards its final area. Other genes which are there is engrailed 1 with the ventral ectodermal cells, since this gene represses regression of the radical fringe. The ridge means the AER is expresses FGF4, FGF8, which maintains the progress zone. And only when this is maintained, there is the rapidly proliferating population of mesenchymal cells adjacent to the ridge. As growth occurs, the mesenchymal cells at the proximal end of the progress zone becomes further away from the ridge, and it influences and begins to slow their division rate and to differentiate, so that towards the later portions, the limb is development is complete and proliferation is stalled. Now, patterning of the anteroposterior axis of the limb is regulated by the zone of polarizing activity, which is, as we said, near the posterior end of the base of the limb bar. These cells produce retinoic acid, which initiates expression of SHH, sonic hedgehog, a secreted factor that regulates the anteroposterior axis. Now, if the retinoic acid or SHS in the anterior margin of the limb is misexpressed, then containing a normal expression of ZPA in the posterior border will result in a mirror image duplication of the limb structure, because the position of the AER and the body axis orientation is equally important. So other genes which come into play during the molecular regulation of the limb development are the EN1, WNT7A, LMX1. In addition, WNT7A maintains SHS expression in the zone of polarizing activity and therefore indirectly affects the anteroposterior patterning as well. Now, all of the patterning genes in the limb have feedback loops. Thus, FGFs in the AER activate SHS in the ZPA, and WNT7A maintains the SHS signaling. So they are all interrelated. Although patterning of genes of the limb axis have been determined in the Hox genes, they regulate the type and shape of the bones of the limb. Thus, the Hox gene expression is due to the combinatorial expression of SHS and WNT7A. It occurs in phases in 3 places in the limb that corresponds to the formation of the proximal, middle, and distal parts of the limb. Genes of the Hox A and D clusters are the primary determinants in the limb, and variations in their combinatorial patterns of expression may account for difference in the forelimb and hind limb structures. Factors which determine the forelimb versus hind limb are the transcription factors TBX5 for the forelimbs and TBX4 for the hind limbs. So this is how they are all expressed in their respective regions to give the development of the respective portions of each of the limbs. Any anomaly, any aberrant expression, whether in relation to time or in relation to organization of their axis, will lead to limb abnormalities. As Gina has very well mentioned about the various abnormal limb conditions, these are the various conditions where you find amalia, complete absence, meromelia, phocomelia, micromelia, or the abnormality of the digits, that is syndactyly, polydactyly. And to see all this, there is something known as the Swanson's classification, wherein all the different types of abnormalities that may be encountered in the limb are classified into 7 types, type 1 to type 7, in this manner. So these are some of the pictures, definitely the pictures which the radiologists see and which we like to see not like to see, which we do see, are different in their appearance, but nevertheless, detecting all of this in the stage when the fetus is in embryo and to take an informed decision by the couple is an extremely important thing to be done. So these are some of the other pictures with conditions of limb abnormalities. This list shows us the various genes which are responsible for development of the different parts of the limbs and their respective locations on the chromosomes, the abnormality, that is a syndrome with which they are associated, and the type of phenotypic abnormalities which they depict. So thank you very much for giving me this opportunity, and I'm extremely sorry for the technical glitch which was there.
Thank you so much, Runmoniba. So I think you should stop sharing your screen.
Yeah.
Okay. Thank you so much. And now I would like to request our president of Society of Fetal Medicine, Dr. Mohit Veerkumar Shah, to speak on the prenatal approach to fetal skeletal dysplasia.
So good evening, everyone. The second webinar, I will be quickly covering the approach to the skeletal dysplasias. Skeletal dysplasias, by definition, are a heterogeneous group of developmental disorders.
Mohit, your PPT hasn't come yet. Yeah.
So they are basically a primary developmental disorders of characterized by abnormal growth of cartilage as well as bone. And it affects approximately 2.3 to 4.5 of 1,000 live births. Like soft tissue tumors, there is an extensive classification of skeletal disorders, and still.
Sorry to interrupt, Mohit. We're only getting the background of your slides, not the actual slide.
I don't know why. Just
Maybe you can stop sharing and share again, perhaps.
I did that once.
So currently we're getting a desktop and a superimposed blank where your PPT is supposed to be.
Now,
We're just getting the background of your slide. No text, no additions. Perhaps if you could open your PPT again after shutting it.
yeah, I did that.
Oops.
Oh, tried everything. Still the same?
Yes, it stops connecting, and so maybe if you can click on your PPT again, the first one rather than the last one.
So first close all your window.
Can you open your PPT and minimize it? And then go into screen sharing.
Yeah. I'll just close it.
Open your PPT, minimize that, go to screen sharing and then take it up.
Oh, still the same?
No, we just
Yeah. Yes, Mohit. Done.
Yeah. Okay. Fine.
Again, yeah.
So,
Fine.
yeah, dysplasias are basically a heterogeneous group of developmental disorders affecting primarily the development of cartilage and bone. And as I said, like a soft tissue tumors, they've got a massive, extensive classification system, and yet so many of them have not yet been classified simply because the gene mutations have not yet been completely identified. So with advances in genetic mutation, we are being able to classify the skeletal dysplasias in various groups. And according to 2015, the latest classification, there are about 436 genetic skeletal disorders which were classified into 42 groups with associated with one or more of 364 genes. So this is purely based on molecular, biochemical, as well as radiological criteria. But what is relevant to us is that only a portion of these disorders manifest during pregnancy, lending themselves to prenatal diagnosis. So this is the biggest challenge that we face. So I believe there are three levels of diagnosis when it comes to ultrasound and skeletal dysplasia. First, you suspect it on ultrasound. Second, you work towards achieving a differential diagnosis. And then, using an algorithmic approach and with molecular confirmation, come to a possible diagnosis. The prenatal molecular DNA diagnosis is important for counseling and decision making, and this can be achieved by doing a CVS in subsequent pregnancies. Postnatal and post-abortal radiographs, autopsy also help to clinch the diagnosis. So when it concerns skeletal dysplasias, if you are aborting it in between, we always encourage to have a post-abortal radiograph so we actually know what is happening with the bones. And an autopsy, if the parents achieved, it will go a long way to characterize the specificity of that dysplasias. So dysplasias basically are phenotypic manifestations of gene mutations and protein expressions. And still, in approximately 25% of dysplasias, the gene mutation has not yet been identified. Ultrasound remains the main imaging modality of choice, but yet it has got a very limited sensitivity, almost a tune of 49-50%. So even what that means is even in 50% of cases, differentiation of the type of skeletal dysplasias is not possible by ultrasound. And I believe there are three main reasons for this. The first being lack of experience of the operator. The second is the rarity of skeletal dysplasias. And third, most importantly, is lack of systematic approach, which we shall address in this talk. So what we want you to do is be patient and methodical, have a structured approach, and learn to recognize patterns. The objective should be improve the prediction of outcome. If you cannot specify, well and good, at least tell the clinician whether this is lethal or non-lethal, whether this will cause various degrees of handicap, advise for the genetic investigation to try and come too close to a definitive diagnosis. And also, a genetic evaluation will provide clues towards inheritance pattern, recurrence rate, because that's the next question that the parents are going to ask, will it recur again? And therefore, these tests will help in prenatal counseling. So the most practical approach to skeletal dysplasia is to ask yourself two questions. Is there a skeletal dysplasia and is it lethal? So if you work on these two questions, you'll probably go and narrow down the differentials. The presentation also varies with gestation. In the first trimester, a skeletal dysplasia can present as a thick NT because of an extracellular matrix, which is very thick. There could be generalized edema. You could have short limbs even in the first trimester, and these are usually lethal. So the earlier they present, the more lethal they are. In the second trimester, femur is the first bone that will be the red flag with associated other long bones and other features which depending on the condition. And the third trimester, apart from the long bones, it is usually polyamnios that will lead you to look further for skeletal dysplasias. So that's what I said in the first trimester, if a dysplasia presents itself, it is usually lethal. So you'll have the most lethal dysplasias presenting early on, like thanatophoric, achondrogenesis, OI type 2, LS1 creval. In the second trimester, you will have those campomelic, diastophoric, and OI types, and all the short thorax, hypoplastic thorax type presenting in the second trimester. Third trimester, apart from all this, the most characteristic to come up later in the third trimester, as we know, is achondroplasia, which starts lagging significantly beyond 24 weeks. So in the first trimester, if you have a thick NT and a normal karyotype, think of skeletal dysplasias. Also look at the skeletal, do a skeletal survey, look at the mineralization, look at the shape, look at the hands and the feet, and it will provide you important clues. You can, it's the best time to do a 3D because the fetus is small. You can use a skeletal mode and study the bones more extensively. You can even look at the femur and identify whether it is bowed or severe micromelic. You can look at hypomineralization. You can identify short ribs. You can identify fractures and therefore diagnose the lethal dysplasias of thanatophoric as well as OI type 2. In the second trimester, you start with femur. That's something that we routinely do in all obstetric scans. So you measure the femur, you find that the femur length is normal. You measure both femurs, see whether they are of the same length. And if there is a discrepancy, how much is a discrepancy? Because remember, an abnormal femur length or configuration is often the first clue towards skeletal dysplasia in the second trimester. And we've often seen reports where it is loosely labeled it as possibility of skeletal dysplasias. But you have to understand that isolated short femur does not always imply skeletal dysplasias. First thing you've got to look at the parents. If they are small, it could be constitutional. Look at the shortened femur. Is it hypomineralized? Is it bowed? Is there a pattern of limb shortening like only the femur? The other segments are normal. You look for detailed scans of aneuploidy because we know a short femur in the second trimester could be a soft marker for Downs as well. So you review Down syndrome screening results, consider karyotyping, and also look at other parameters to exclude a potential early onset severe growth restriction, also including Dopplers in between. So if you find that one bone is involved, always measure all long bones, diaphysis to diaphysis. Make it a habit of doing a complete skeletal survey, measuring the femur humerus, radius ulna, tibia, fibula, and putting them in the graph. So when you measure them, you should have a checklist when you approach the long bones. So is there a shortening? What is the degree of shortening and what is the pattern of limb shortening? Is the shape normal as with bowing fractures? Is the mineralization normal? Is the extremity absent, cut off in any which way? And look at the epiphysis. Is there premature ossification of the epiphysis? Then the next question is how short is short? So always calculate FL in respect to standard deviations. If you have 2 to 3 standard deviations below mean, well, you can still follow up because this could be constitutional. If you have the higher you go, the higher standard deviation it goes, it is likely to be a skeletal dysplasia. And if it is significantly higher, then it is usually a micromelic skeletal dysplasia, which is usually lethal. So the most important take home is the more the standard deviation below the mean, the long bones, the worse is the prognosis. And earlier the long bone shortening is seen, the worse is the prognosis. So many a times in our scenarios, the patients are not sure of the exact LMP, or they come with no previous reports. So how do you then assess the long bones? And a simple way is to use the femur to foot length ratio, because the logic and the logic of using this ratio is that the foot length is approximately equal to FL throughout the gestation. So if you take the foot length to femur length to foot length ratio, it should always be 1. If the femur starts logging, then it will start reducing. And if it is less than 0.9, it suggests skeletal dysplasia. If it falls than 0, less than 0.6, that means the femur is extremely short, and therefore it points towards a lethal skeletal dysplasias. The next is to look at the pattern of limb shortening. If the proximal segment is narrow, shortened, it's rhizomelia. If the middle segment, mesomelia. If the terminal segment is acromelia. And if all 3 segments, it's micromelia. You have to use these terms judiciously, because this is the way you will narrow down your differentials. So the commonest rhizomelic dysplasia is achondroplasia, which typically has late onset, homozygotic when you have both parents involved, is lethal. We see the commoner heterozygous achondroplasias, which present with late onset macrocrania. You will find that there will be a frontal bossing, there will be a depressed nasal bridge, there will be a trident hand, meaning that there will be a gap between the 3rd and the 4th fingers. We do not appreciate the lumbar kyphosis unless you attempt to do a 3D. But the worst problem is that these are compatible with life with a normal intellect. Yet we cannot always diagnose them in the anomaly scan, and the parents and the obstetrician should be made aware of this. So if you have a rhizomelic pattern, I can think of 3 dysplasias: achondroplasia, diastrophic dysplasias, and asphyxiating thoracic dystrophy. So idea here is to break down into individual characteristics so that we identify a specific diagnosis to that rhizomelic pattern. So in achondroplasia, I'll see frontal bossing, macrocrania, and trident hand. In diastrophic dysplasia, there will be joint contractures, micrognathia, but a typical hitchhiker's thumb, where there will be persistent hyperadduction of the thumb. And in asphyxiating thoracic dystrophy, the most prominent feature will be polydactyly with thoracic hypoplasia. When you come in the 3rd trimester, first thing that you have to think of is statistical variation, because that's the commonest cause of a small femur in the 3rd trimester. And then secondly, you will think of the fetal growth restriction before you start thinking of skeletal dysplasias. So once you've identified short long bones, next you look for hypomineralization and you look for fractures. So if you have fractures in the long bones, you could think of osteogenesis imperfecta type 2 or achondrogenesis. But then you need a very specific diagnosis, because OI type 2 has a low recurrence risk, whereas achondrogenesis is autosomal recessive and has a 25% recurrence. So what then I would do is look for ossification. If I find that the skull is hypomineralized, I do not see the ossification well, I am seeing the ipsilateral brain too well, I can compress the skull. That means I am dealing with the hypomineralized skeletal dysplasias, OI type 2, achondrogenesis, hypophosphatasia. And if I need to then zero down into 1, I'll go and look at the spine. In achondrogenesis, there will be non-ossification of the spine, whereas in OI type 2, the spine will be fairly ossified. And that's the way I can separate out a micromelic dysplasia with fractures. The OI type 2 form achondrogenesis by just simply looking at the spine. So OI has multiple types. It is autosomal dominant with low recurrence. Type 2 and type 3 they present prenatally. Type 2 is lethal with severe micromelia and fractures. There will be short the rib cage and hypomineralization. Type 3 presents late in the second and third trimester. It generally presents with fractures, and therefore these feti, even when you take it to term, will have multiple motor disabilities. So OI is typically micromelia, fractures, hypomineralization, and short ribs, the ribs ending short there. And this is typical type 3, presenting in the late third trimester. The radius and ulna are fractured. You see this frontal bossing of the forehead, OI type 2. Achondrogenesis is also an hypomineralization disorder, but here there will be diffuse hypomineralization, especially of the spine, and that's one differentiating feature. Also, there will be micrognathia. So if you identify platyspondyly, you will think of thanatophoric dysplasias. And one way to identify platyspondyly is to see the ratio between the height of the vertebrae with the adjacent vertebral bodies. And normally the height of the vertebral body is larger than the adjacent disc space. But if you have a collapsed vertebral body, the disc space will be larger than the collapsed vertebral body, and that will suggest platyspondyly, which is a feature of thanatophoric dysplasias. Thanatophoric is the most common lethal skeletal dysplasias. They have a de novo mutation, so fortunately they have a low recurrence, but they have this typical secure micromelia, narrow thorax, and there are two types. In the type 1, you have that classically described French telephone receiver appearance of the long bones where they are short, curved, and bowed bones. In type 2, you will have the clover skip skull, the triradiate skull with short, straight bones. So type 1 and type 2 are different. When we talk about French telephone receiver, clover leaf, we all generalizing thanatophorics, but type 1 typically has French telephone receiver and type 2 has a clover leaf skull. So you see, a clover leaf skull looks something like a craniostenosis, but you will have hypomineralization, you will have a short rib, you will have the rib abdominal discrepancy, frontal bossing, severe micromelia, and that's very classical type 2. Type 1 is the classical telephone receiver bowing of the femur, and that's type 1. Hypophosphatasias is autosomal recessive, and the diagnosis of exclusion is primarily basically by exclusion only. But the good thing about this type of dysplasias is that you look at the clavicles and you find that the clavicles are fairly mineralized. You will probably say this is hypophosphatasia. So if you look at each and every bone, you'll probably narrow down the differential to arrive at a much specific diagnosis. Now, if you look at the chest, normally you see the ribs reach up to the sternum, almost 2/3 along the circumference. If they stop short, they are hypoplastic. And it's a subjective assessment that the thorax looks much smaller than the abdomen, seen both in axial and best in coronal, where you will find that there is that bell-shaped deformity of the thorax and the chest-abdomen discrepancy. And a small thorax will be seen in thanatophoric dysplasias, achondrogenesis, all shortly polydactyly syndromes, all asphyxiating thoracic dysplasias, and osteogenesis imperfecta. Basically, all dysplasias which define lethality. So lethality is because of a short thorax preventing the lung to develop, leading to pulmonary hyperplasia. If subjective assessment is not sure, you can actually use ratios. Chest circumference to AC ratio of less than 0.6 and FL to AC ratio of less than 0.16 are more objective criteria to say or predict lethality in these cases. So in thoracic dysplasias, in thoracic hypoplasias, in OI, you will have severe micromelia with fractures and hypomineralization. If you have a hypomineralization, particularly the spine with micromelia and micrognathia, you will think of achondrogenesis. If you have micromelia with cloverleaf skull and hypomineralization, you think of TD. Hypophosphatasias when you have a sparing of clavicles with micromelia and hypomineralization. And when you have hypomineralization, polydactyly with severe micromelia, and you will think of a short-lived polydactyly syndrome. So asphyxiating thoracic dystrophy is a short. It's again a differential of a narrow thorax where you have a 25% recurrence rate with a presenting with rhizomelic limb shortening. So if you look at the three main features of lethality, that is severe micromelia, thoracic hypoplasia, and diffuse mineralization, you will have four differentials in mind: OI type 2, achondrogenesis, hypophosphatasia, and short-lived polydactyly syndrome. They present with all the three features defining lethality. In OI type 2, you will have ubiquitous fractures. In achondrogenesis, you will have micrognathia. In hypophosphatasia, you will have clavicle sparing. And in short-lived polydactyly syndrome, you will have polydactyly. And that's the how you will narrow down on the differential to reach a specific diagnosis. In TD, you will have severe micromelia with thoracic hypoplasia. So short-lived polydactyly syndromes are again thoracic hypoplasias with polydactyly, autosomal recessive, so 25% recurrence rate. Ellis-Van-Creveld will have a skeletal dysplasias with congenital heart disease, again autosomal recessive with 25% recurrence rate. If you find that there is just about bowing with shortening of the limbs, you can think of campomelic dysplasias, OI type 3 and 4, and TD type 1. In campomelic dysplasia, the classical feature will be ambiguous genitalia, micrognathia. In OI, you will have fractures late onset, and bone mineralization generally is narrow, but you will present with late onset fractures and bowing. And TD, you will have this classical telephone receiver with cloverleaf skull. So campomelic dysplasias presents with bowing of the femur, but you have only bowing of femur, or if you just have bowing of the long bones, make sure that you do a comprehensive skeletal survey. Where features typical with campomelic dysplasias are ambiguous genitalia, micrognathia, and scapular hypoplasia. So if you have these three features, you will think of campomelic dysplasias. So one thing that you realize while we stand is we have to look at each and every bone. So your checklist should be you put the femur into the standard deviation to find out how short it is. You use the femur to foot ratio. If your LMP is not sure, confirm whether the bones are short, which ones, what is the pattern of limb shortening, are they bowed, is there hypomineralization, are there fractures, how is the chest looking, what is the shape of the head and the ossification there, how does the facial profile look at the spine. Hands and feet provide important clues, include scapulae, clavicle and pelvic bones. So in short, do a comprehensive skeletal survey. Look at the epiphysis. Sometimes premature stippling or epiphyseal ossification can point towards chondrodysplasia punctata. Always look at the facial profile. Frontal bossing will be seen in TD as well as achondroplasia. You will have micrognathia as a feature in diastophoric dysplasias, campomelic dysplasias, and achondrogenesis. Hands and feet, as I said, give important clues. So this is extremely important to look at all digits of all four limbs. You will have clinodactyly as a feature of aneuploidy, but you will have hitchhiker's thumb as diastophoric dysplasias. in achondroplasia, you will have trident hands where you will have a gap between the third and the fourth finger. You have hyperadduction of the thumb, classical feature of dystrophic dysplasias, which again are present as talipes, hitchhiker's thumb, micrognathia, and joint contractures, autosomal recessive again. Polydactyly, if associated with a narrow thorax, points towards a shortly polydactyly syndrome. Isolated polydactyly is not considered a skeletal dysplasia. Do be mindful of that. Talipes can be associated with aneuploidy as well, but is again a feature of dysplasia, especially when you have a disorder of the skeletal system. So you rocker-bottom feet is separate and has to be viewed differently from a talipes. Rocker-bottom is generally favors aneuploidy than a skeletal dysplasias. So if you have a radial ray anomaly where you will have a abnormal curvature at the level of the wrist with absent radius, again it features more towards Fanconi's and TAR and all those hemopoietic syndromes, but this is something that presents as an absent radius and an absent thumb, and therefore this has got more significance than an absent ulna. So a radial ray is more likely to be associated with syndromes than an absent ulna. So scapulae can be best seen when you do a 3D on a prone fetus, where you can identify both scapulae and compare the sizes. You have nomograms for scapulae as well. Remember, scapular evaluation is important because scapular hypoplasia can lead you to a campomelic dysplasias. So lethal skeletal dysplasias are the one that present with early onset with severe limb shortening. They present with small chest and small ribs. They present with fractures or marked bowing. You could have an abnormal skull shape with hypomineralization. They could present with head drops. So if you have to need an objective criteria of lethality, you can check the chest circumference and abdominal circumference ratio of less than 0.6 or an FL to AC ratio of 0.16. So the commonest lethal dysplasias are the sthenotophoric dysplasias, OI type 2, achondrogenesis, and all those dysplasias which present with a narrow thorax, shortly polydactyly syndromes, hypophosphatasias, asphyxiating thoracic dystrophies, most of the campomelic dysplasias, and most of the Ellis-Van-Creveld syndromes. The only truly non-lethal skeletal dysplasias is an achondroplasias. Dystrophic dysplasia is lethal in 25%. OI type 1 and type 4 may fit into it, but they still end up with motor disability. And therefore, the only true non-lethal skeletal dysplasia is actually achondroplasia, heterozygous achondroplasia. Why is that important? Because we have to know that various dysplasias have a genetic predisposition. Thanatophoric typically is a de novo mutation. So though it is universally lethal, we know that because it's a de novo mutation, it is a low recurrence rate. And same goes with to OI type 2 and campomelic dysplasias. On the other hand, dysplasias which are autosomal recessive, like Ellis-Van-Creveld, like dystrophic dysplasias, like shortly polydactyly syndromes and achondrogenesis, because they are autosomal recessive, they have a 25% recurrence rate. Therefore, we have to know the inheritance pattern. Recurrence rate differs in different conditions, and this is extremely important in future pregnancy planning as well as management planning. So we do recommend CVS and amniocentesis in subsequent pregnancies. If you have worked up an index case, which we always recommend, then all you need to do is you do a specific mutation analysis by doing a Sanger sequencing. If there is no previous history of an affected child, then you can do a whole exome or a clinical exome sequencing or a targeted skeletal dysplasia gene panel. You can even do trials, that is, you sample the parents with the fetus, especially to validate variants of unknown significance. Always recommend storing DNA. If you have aborted the fetus, you can take the DNA from the abortus and always end up doing an X-ray or an autopsy, at least recommend for an autopsy. They may or may not accept, but radiograph, certainly you can ask the obstetrician to get a basic, fetogram, that is entire fetus's X-ray, so that we know how it collaborates with an ultrasound finding. Genetic diagnosis aids in counseling the couple regarding the spectrum of phenotype, including lethality, prognosis, and recurrence risk. So be systematic in your approach. Pattern recognition always helps. Most importantly, try to recognize lethal versus non-lethal. This can help in counseling, planning delivery, and post-delivery management plans. Remember, whatever you do, not every case can be assigned a specific diagnosis. What you should aim to come close to a diagnosis, because recurrence risk differs for different conditions. Autosomal inheritance has a 25% recurrence rate that might alter the parents' reproductive plans. You can refer to this paid website for further research or understanding the International Skeletal Dysplasia Registry. Thank you very much.
Thank you so much, Dr. Mohit, for a fantastic talk and for making such a complex topic so simple and giving us clarity. So now we have case presentations from our members from the Northeast, and I'm indeed so proud to say that we've had so many people coming forward expressing their interest to present the work. So at the outset, I would like to request Dr. Jaharlal Bedder to present his case. He's a professor, Department of Obstetric and Gynecology in the Agartala Government Medical College and GBP Hospital. He's also the treasurer of SFM Northeast chapter, and he has done his graduation and post-graduation from JIPMER, and he has a teaching experience of 24 years and is an examiner for undergraduates, postgraduates, as well as DNB exams. So over to you, Dr. Baidya. You can share your screen and present your case.
Is it visible, ma'am?
It is.
Yes.
You just go to slide share and full screen.
Full screen. It's not full screen, ma'am.
No. I think there's something at the top. You just have to go to full screen.
I have his presentation. If he wants, I can share his presentation.
Please do it.
So please stop sharing the screen, sir.
Okay. Good evening, ma'am. I bring greetings from the Agartala, northeast of India. Am I audible?
Yes. Yes,
Okay.
Dr. Baidya.
First of all, I'm very thankful to this SFM family for allowing me to talk on the topic or a case presentation that is on unilateral mesomelia with the bilateral clapboard. Next, please. So I'll be going through this case history, and later on I'll be talking a little bit about this particular case, how we have diagnosed and how we have managed. This particular lady, she is a 32 years. In her 10 years of married life, this is her second pregnancy, which was a planned pregnancy, and she came to the OPD of our medical college with the imaging report that suggests that fetal skeletal anomalies. So she belongs to a upper middle class family, and she was also the case of post-CS pregnancy. Next slide, please. So the history of her present pregnancy, it was a spontaneous and planned pregnancy, and she did not have any sort of history of exposure to teratogenic agents or any other environmental factors. And on evaluation of her history, we could find that she was only having a subclinical hypothyroidism, and for that she was on treatment for a levothyroxine 25 mg. Next, please. The past history, nothing very significant. She is having a 8-year child who is completely normal, development, everything is normal, and she had undergone cesarean section for the same pregnancy. Next slide, please. Nothing significant in the family history. We could not find anything related to this kind of disorders. On clinical examinations, she was an average build person, normotensives, and her obstetric examination revealed that she was having a 22 weeks of pregnancy and with a cardiac activity could be demonstrable by the auscultation. Next slide. And the relevant investigations, what we could find from her history and other things, the routine investigations were normal. The special investigation that she had and she was carrying along with her, that was the investigation, that is the 2D ultrasonography was done at 13 weeks, which was completely reported as a normal. And that sonography report also shows that normal NT and NV measurements, and she was not offered any dual marker test. Next. So the next ultrasonography, what she was having, for which she has attended this OPD, and that shows that the single viable fetus of about 19 weeks, showing this right-sided mesomelic limb, and with the bilateral CTEV. The sonologist had diagnosed to also found that there is a bilateral renal pylectasis. So it was diagnosed by a sonologist and said that the fetus is having right-sided mesomelia and also suspected to have a campomelic skeletal dysplasia. With that report, we had gone in counseling along with her. Next slide, please. Next slide. So this is the sonography report. So we talked to this the couple and we discussed about this particular condition, skeletal dysplasia, and how to go about whether to require any further investigations or not. We suggested that you should be attending a fetal medicine center for the further investigations. And we asked her to get a investigation done in outside the state because we don't have any designated fetal medicine center here. Next slide, please. So at 20 weeks of pregnancy, when she had reached to a fetal medicine center where the detailed ultrasonography was done, which specifically directed towards the skeletal survey, along with this survey of all the long bones, clavicle, scapula, that is a systematic manner, as we heard actually how it should be done, and orientation of the hands and feet, then looking into the spine, skull, and the rib cage and thorax, etc. So this next few slides will be showing that some of the findings, which shows that absolutely normal left leg with the bone length which is normal, but this right tibia and the fibula was found to be shorted. And this, according to the measurement, those are not corresponding to the period of gestation. Next. So this is this again, the showing this fetal lower limbs and also found to have a bilateral CTEV, both legs. Next slide, please. This is again to show about this limb measurements and show that only the right limb is having this dysplasia, skeletal dysplasia along with the CTEV. Next slide. So this particular, the video, can you play this video, please? Just click on that. Okay, there's no problem. So this is actually the showing this video showing the legs and the CTV and also the mesomelic right lower limb. Next slide, please. Yes. So, and others upper limbs and face and spines that has been detected to be normal. Next. Then also orientation of the other parts of the body, that is the scapula, the clavicle, spine, those found to be normal. Skull and face also found to be normal. And the kidney shows, the bilateral kidney shows this pylectasis. Next slide. So this particular lady was counseled again and asked for this amniocentesis, which actually, I'm sorry, that slide I think not very well visualized. And was opted for this testing whole exome sequence, which was advised, and the report is as follows. Next slide. I just wanted to mention about what is written in this. Probably it will be discussed by the genetist. So it was actually a short rib thoracic dysplasia 10 with or without polydactyly, that is SRTD10, which was a heterozygous mutation of the gene called IFT172. And it was also mentioned that it was an autosomal recessive. So she had come back to our CT with these reports, and we also had a discussion with the genetist and the fetal medicine center, what next option we have with us with this management of this case. Next slide, please. Next slide, please. So the final opinion, what we had about this lady who is a second-time mother, who is having a single viable fetus with the 20 weeks of gestation, mesomelic right lower limb with a bilateral CTV, and also having this bilateral pelvic cholectasis. This final diagnosis that was gathered from this genetic test also, that was a SRTD10 with a heterozygous mutation. And she was again discussed about the termination of pregnancy because of the nature of the disease. Next slide, please. So counseling and management, this always is very important to manage this kind of patients, where we require actually multidisciplinary approach, because genetic counseling also has to be discussed about how to manage the next pregnancy or the postnatal management. Next. So they discussed with the genetist and planned for the termination. Next slide, please. We have terminated the pregnancy as per the FIGO guidelines. It was a male abortus weighing about 250 grams. Post-abortion moderately anemic, which was corrected with this iron therapy. Next, please. This is this photography of the fetus, which is showing this right-sided fetal mesomelia and also bilateral CTV. Next slide, please. So follow-up in the postnatal period was uneventful. Next slide. So if I have a permit to talk for a few minutes more, then I'll be discussing about, I think, almost all things should be repeated. And just pertaining to this case, we would like to discuss about what is mesomelia, different types of skeletal dysplasia, what is lethal, non-lethal, already been discussed. What is the challenges that is been found in this case of this diagnosis of fetal skeletal dysplasia? Next slide, please. So as already been mentioned that this, we find it is a 1 in 4,000 live births. Majority of them, either they are in a 25% may have a stillbirth and 30% die very early in neonatal period. And there are wide range of skeletal dysplasia with specific recurrence. That is a main concern of management of this case, because we have to also counsel for the future pregnancy. There are, of course, there are some incidental discovery of the skeletal dysplasia on routine screening. Next slide, please. And as we already know that how to type those cases of a skeletal dysplasia, we have to evaluate the long bones, and we have to also see the different parts of the hands and feet. I'm not going to discuss in detail because it's already been discussed. Next slide, please. I just want to spend some time here to understand this different different types of skeletal dysplasia. This has also been discussed. What is rhizomelia, what is mesomelia, acromelia, micromelia, and camphomelia. What this case, what we are having as a mesomelia, that is the shortest part of this middle parts of this, either of the arms or a lower limbs. In this case, we have a right-sided lower limb. Next slide. And already been discussed, I'm not going to touch upon this, just to understand that what kind of the dysplasia, whether it is a lethal or non-lethal, because while we are sitting with the couple and counseling, we must know about it, what kind of the skeletal dysplasia the baby is having or fetus is having. According to that, we have to counsel and go further, whether to continue the pregnancy or terminate the pregnancy. Next slide, please. And this is very important because even I was wondering why this particular case we have missed, or we have could not diagnose in the very first trimester of pregnancy itself. But I could find out there's a different timelines of diagnosis of skeletal dysplasia. That is very interesting to note that the most of the skeletal dysplasia is better identified in this beginning of the second trimester, and maybe in the very late first trimester. So that is to note and also to understand that as an obstetrician, that when it can be diagnosed and also can be commented on about the skeletal dysplasia. Next slide, please. The factors that can affect this early detection, that is, of course, it is well understood that the more the severe conditions of a skeletal dysplasia that can be detected much earlier, because that comes very obvious to this examiner. And of course, it all depends on the experience of the sonologist to detect. We heard actually Dr. Gina talking about the different parts can be examined in systematic manner and how to find out in early pregnancy itself. And of course, all depends on this quality of the machine, what we use it. Next slide. Next slide, please. To conclude this my talk, this is a very the case what I have seen in our OPD, and it makes us to understand that detailed assessment and confirmation of the most of the skeletal dysplasia should be known to the obstetrician, and also to know that when that can be diagnosed and how early we can diagnose, and plan the further confirmation of this particular conditions. Also, at the same time, when to terminate, when not to terminate. Advanced imaging technology and prenatal genetic testing is always good to add on to find out the reasons, or try to find out the genetic aspect of it. And also it confirms the diagnosis. Counseling and tailoring the management is very important in this aspect of this management of this kind of the skeletal dysplasia. And of course, it is very important to counsel the family members. Thank you very much. Next slide, please. And I again thank this the family of the SFM for this opportunity. Thank you very much.
Thank you, Dr. Baidya. That was a fantastic presentation. So our next presenter is from Sikkim. She is Dr. Seten Zangmu Bhutia. She has done her MBBS and MS from the Manipur University, Imphal, India. And then she did her postdoctoral fellowship in fetal medicine from Fernandez Hospital Foundation under the aegis of Kaloji Narayana Rao University of Health Sciences. She is also trained in fetal echocardiography and certified from the Fetal Medicine Foundation. So today she shall be presenting two cases. One is on split hand malformation at NT scan, and the second one is Roberts syndrome diagnosed at 20 weeks. So over to you, Dr. Seten. Yeah, Dr. Seten, you can start. We can see your screen. Yeah. Is there a problem? I mean, wait.
No audio actually.
Yeah.
Could you check your audio device that is properly connected or not?
Just a moment, I'll call her.
Hello, is it visible?
Yeah.
Audible?
Yes,
Yes,
Dr.
yes.
Seten, you can start. Yeah.
Sure. Yeah, I'm Dr. Shiten from Gangtok, Sikkim. Without much ado, I'm going to share some interesting cases on limb anomalies. So my first case, she is 28 years, primary gravida, spontaneous conception, non-consanguineous couple. She came to us at 12 weeks, 5 days for NT scan, where NT measurement was normal. When we look at the structural survey, we found here in the coronal section that the open hands were not visualized. And when we want to see the limbs individually, we see here that the humerus on both the side and ulna and the radius was well visualized, but we cannot visualize all the fingers and only the 5th digit was seen. Some ossification of the metacarpals were visualized, but it wasn't much clear. When we look at the lower limb, we see here that bilaterally the femur length looks normal. When we see the other lower limb bones like tibia and fibula, it also look normal along with the orientation of the ankle. The joint movement at the upper limb and lower limb appeared normal. But when we look at the feet, we see here a deep median cleft on both the side. So this is the 3D rendering image of the same fetus where we can see clearly a single 5th digit is visualized on both the side, which is known as monodactyly. So when we look at the pedigree, we see here that the husband or the father of the fetus, along with the grandfather, both were affected with ectrodactyly. Also, his brother and the niece and nephew was also affected with the same. And there was no problem of skin, hearing, or vision in any 3 generations. So it was a case of non-syndromic split hand-foot malformation. Karyotype of the couple was also done elsewhere, which was normal. When we examine the father, we see here, this is the picture of the father's hand where monodactyly is visualized on both the side, and also on the left side, a hypoplastic proximal phalanx is visualized. When we corroborate it with the X-ray finding, we see here that the long bones are normal on both the side. The 1st and the 2nd digits are totally aplastic. The 3rd metacarpal is hypoplastic. 4th metacarpal on both the side appeared normal, but the proximal phalanx looks hypoplastic. Only the 5th digit is present, but also there is a flexure deformity on both the interphalangeal joint, which is known as camptodactyly. When we examine the legs here, we can see deep midline cleft on both the side. And when we corroborate it with our X-ray finding, we see here that the 2nd, 3rd, and the 4th metacarpal are hypoplastic and fused, giving a typical lobster claw-shaped appearance. So at this point, when we did her counseling, the couple was not ready to undergo any prenatal invasive testing, and they wanted to wait a little longer, hoping for more digits to develop, which could aid in functionality later. So we relooked at the fetus at 16 weeks and we found the same finding again. In upper limb, there was bilateral monodactyly, and in the lower limb, in the feet, deep midline cleft was visualized. All other long bones appeared normal for the gestation. So after 16 weeks, she finally opted for amniocentesis, and DNA isolation and storage was done for genetic evaluation later because of a financial constraint. Rather, the couple opted for fetal autopsy. So coming to the sonopathological correlation, this is an infantogram showing the spine, the clavicle, the scapula, ribs, and all the other long bones appeared normal, except for the thing that we had already seen, bilateral monodactyly in the hand and deep midline cleft in the feet. This is the autopsy picture of the same, where it is consistent with our scan finding. So we know it is a non-syndromic split hand-foot malformation, but we do not have a molecular diagnosis yet, so the type is unknown. So she came back again in 2nd and 3rd pregnancy, and both times during NT scan, she was diagnosed with split hand-foot malformation. These are the images of the 2nd picture and the 3rd pregnancy, where the phenotype is almost same of monodactyly and split median cleft in the feet. And both the time she was suggested to undergo whole exome sequencing for the father or the fetal DNA, which was stored in the 1st pregnancy. Also, the option of IVF with pre-GD or IVF with sperm donor was discussed, but unfortunately, both the times without any investigation, she went for termination of pregnancy. So before planning for a 4th pregnancy, she finally went for a proper genetic workup, and we sent for a whole exome sequencing, which did not reveal any pathogenic variant. Followed by, we had done chromosomal microarray of the father, and the DNA which was stored from the 1st fetus which revealed a gain of 481 kilobyte involving chromosome 10q24.31, Q24.32. And the genes involved in these regions are as follows. So our final diagnosis is split hand foot malformation type 3. So talking a little bit about this malformation, earlier it was termed as ectrodactyly, but the terminology is no longer singularly used and it has been merged in this spectrum. It is a congenital limb malformation affecting the central rays, which can cause syndactyly, median cleft of the hand and feet, like we see in this image, and the below feet image. Also, there can be aplasia and hypoplasia of the phalanges, metacarpal and metatarsal, that we see in this B image, where the thumb as well as the median rays are totally aplastic, leaving behind a single fifth digit. So the prevalence of this disease is 1 per 25,000 live birth. It could be isolated or as a part of a syndrome, and it could also be associated with micronathia, cleft lip, or palate. So there are 7 types documented in literature so far. It could be single gene disorder or a chromosomal copy number variant. It could be autosomal dominant, recessive, or X-linked. Our kind was 3rd type. So it is because of the duplication in the 10th chromosome, and it is an autosomal dominant type. So this malformation, it has a complete penetrance with variable expressivity. Complete penetrance means if there is a mutation in the person, the disease will be manifested. In variable expressivity, there is none in this. That means if there is a disease manifested in a person, the phenotype may vary from person to person, or even in a same person, there might be a different phenotype in different limbs. So the recurrence rate is 50%. So she was suggested to undergo prenatal invasive testing with chromosomal microarray in consecutive pregnancy if she plans. So moving on to my second case, she is 29 years primi gravida, 3rd degree consanguineous couple, IVF conception. NT and combined first trimester screening was done elsewhere, which stated low risk for trisomies, and there was no history of fever, rash, or teratogen exposure. So this is a pedigree showing there was a 3rd degree consanguinity, but no significant family history. She came to us at 20 weeks for TIFA scan, where we see that all the biometric parameters are less. So it was an early onset fetal growth restriction. When we see the upper limb, this is the humerus, which was very short, -3 standard deviation. And this is a short clip demonstrating the upper limb, where we see here that the humerus is visualized, which is short. The forearm bone, a single hypoplastic ulna was present. Radius was absent, and there was a club hand on both the side. When we look at the lower limb, the femur was again short, -4 standard deviation. Left lower leg, the tibia and the fibula was present, but it was hypoplastic again. On the right side in the lower leg, only a single hypoplastic curved bone was visualized. There was bilateral talipus. And this is a short clip demonstrating the same features that I have just explained. So we can see that the lower leg is hypoplastic, bilateral talipus on both the side. There was also a flexion contraction deformity both at the elbow and as well as the knee joint. In systemic examination, we see that the aortic arch is on the right side of the trachea. So it is a right aortic arch with left ductus arteriosus. Hypertelorism, wide set eyes are there. There is a unilateral cleft lip as well. This is a 3D rendering image showing the unilateral cleft lip. So at this point, we have sent for amniocentesis and trioexome sequencing. So looking at the sonopathological correlation, this is an infantogram showing a well-ossified skull bone. The ribs, spine, clavicle, scapula look normal, but there's a micromealic shortening of upper limb and lower limb, where we see absent radius out here with bilateral club hand and bilateral talipus. So this is an autopsy picture showing again the flexure contracture at the upper limb and lower limb joint. And when we see the face, it is dysmorphic, where we see the broad forehead, downward slanting palpable fissure, unilateral cleft. The malar prominence is also flattened and low set ears. So this image shows that the heart is pointing to the left and the arch is on the opposite side. So this represents right aortic arch. We also see the fingers carefully, and here we found that there was a short thumb as well as the fifth digit was small, so which is known as brachydactyly. This image shows contracture deformity at the knee joint with bilateral talipes. There was also clitoromegaly with ambiguous genitalia, and this bony spur was visualized on the thigh as well as just above the shin, which was a novel finding, has not been documented in literature so far, but I found while seeing in the literature that it can be associated with hypophosphatasia. So by then, our trio exome sequencing report was ready, which stated that there was a mutation in SCO2 gene, which is a pathogenic variant, and it is an autosomal recessive type. So couples were carrier for the same. So my final diagnosis is Roberts syndrome, and the recurrence rate in each pregnancy is 25%. So she was counseled to do targeted testing for SCO2 gene in subsequent pregnancies. So in short, I want to talk about this Roberts syndrome, that it is due to mutation in SCO2 gene on chromosome 8, which encodes a protein responsible for regulating sister chromatid cohesions. There can be multiple multi-system abnormalities. These are fetal growth restriction, involvement of limbs, craniofacial abnormality, renal system can also be involved, cardiovascular system, and urogenital abnormality is also documented. So the prognosis entirely depends on severity and degree of malformation, also if other organs are involved. So at last, to summarize my cases, first trimester is an ideal time for limb examination as fetal movements are frequent and hands are often open. So we should have an increased vigilance in couple at high risk for these anomalies based on personal and family history. 3D sonography can be excellent adjunct to 2D, especially in first trimester for diagnosing such complex malformation. It also helps in counseling and provide guidance for surgical treatment options and other decision-making processes. Proper and prompt diagnosis can encourage accurate genetic counseling, educate mother on recurrence rate in siblings, and possible prenatal diagnosis. At last, I would like to thank you, the whole Society of Fetal Medicine, for giving me this platform to share my cases. Our geneticist, Dr. Gayatri, who has always helped us in such difficult and rare case scenario. My whole Fernandez family for backing me and supporting me. And not to forget to all the fetus who have been the greatest teacher and who have taught us the immense knowledge that we have gained so far. Thank you.
Those were wonderful presentations, Dr. Shaten, and so well worked up. Congratulations.
Thank you, ma'am.
So our next presenter is Dr. Zora Ahmed. She's from Guwahati, and she has done her MD radio diagnosis from the All India Institute of Medical Sciences, Delhi. She's a fellow of the Royal College of Radiology and also a fellow of Advanced Obs and Gynae Ultrasound from Mediscan Systems, Chennai. And presently, she's a director of AVA Clinics and Fetal Center in Guwahati, and also a consultant at the Institute of Human Reproduction. So today she will be presenting a case on rocker bottom foot with scoliosis at 21 weeks. So over to you, Zora. Yeah.
Good evening, everyone. Am I audible?
Zora.
Yes,
Please.
Okay. So I will move on to the case presentation of Mrs. S, a 40 years old lady, primary gravida, conceived naturally, blood group was AB positive. First trimester scan done normal, NT was 1.8, nasal bone was present. First trimester screening was intermediate risk, T21 of 1:363. Papi and beta HCG were normal. So she came for anomaly scan at 21 weeks, 4 days. Growth and Leica was normal. The lower limbs were abnormal, and we could see I could see an abnormal contour to the feet with a bulbous convexity, prominent heel, and also a convex plantar surface. So the lower limbs were also persistently flexed. Some movement was seen, but full extension was never documented. Also, the muscle mass appeared to be less than normal. So these were the 3D images of the same, nicely showing the prominent contour of the heel along with inferior convexity of the plantar surface. So moving on to the spine, the normal parallel orientation of the anterior and posterior elements was very difficult to demonstrate on screening of the spine. And this was nicely seen on the 3D image that there was severe scoliotic deformity of the spine. However, no segmentation defects could be identified. So moving on to the hands, there were tightly clenched hands without any open hands demonstrable. Also, the hands were persistently flexed at the elbow in front of the face. Additional findings were increased nuchal fold thickness, increased prenasal soft tissue, and scalp edema. These were the 3D image of the face. So to summarize, there was bilateral rocker-bottom feet, legs were in semi-flexed position, muscle mass appeared to be reduced, clenched hands, upper limbs appeared in semi-flexed position at elbows. There was scoliosis of the spine. The curvature was abnormal, but overlying skin appeared intact. There was increased prenasal soft tissue thickness and increased nuchal fold thickness. The pedigree, family pedigree was taken and was not significant. So coming to the counseling, in view of the above findings, the semi-flexed position of limbs along with reduced lower limb mass and nuchal edema, the provisional working diagnosis was evolving arthrogryposis. Etiology could be single gene disorder. The other DD could be chromosomal trisomy 18. So I suggested direct testing by amniocentesis for CMA and DNA storage. In case CMA was normal, then further testing would be recommended, especially whole exome sequencing. And this testing would be helpful to assess the etiology and also to plan the pregnancy in the future. But in view of multiple findings, prognosis of the fetus was guarded. Patient was extensively counseled for need of direct testing. However, they refused the same and they did not go back to the primary obstetric physician and they were lost to follow up, unfortunately. So rocker bottom foot is a rigid foot deformity with fixed vertical position of the talus and dorsal dislocation of the navicular with respect to head and neck of talus. The deformities that are caused are midfoot dorsiflexion and forefoot abduction. So the difference between a normal foot, rocker bottom, and club foot is as follows. Normal foot, this is the normal contour of the heel with a concave plantar surface and tapering distal foot. Rocker bottom has a bulbous heel and a convex plantar surface. And club foot, the heel is less prominent, foot fans out distally, and the side of the foot facing plantar direction is flat. So Rubio et al. Studied congenital vertical talus or rocker bottom foot as a marker for multisystem anomalies. They had 24 cases, of which all of them had associated anomalies. 1/4 of them had chromosomal abnormalities, including trisomy 18 and other copy number variations and single gene disorders as well. So there were very many associated anomalies with rocker bottom foot, including upper limb abnormalities, clubbed wrist, abnormal hand digit position, umbilical cord abnormalities, abdominal wall defects, lower limb abnormalities, including club foot, multi-level abnormalities, including arthrogryposis, spinal abnormalities, including scoliosis, myelomeningocele, cardiac defects, and also intracranial abnormalities. Facial abnormalities were also associated with rocker bottom foot. Earlier studies have reported additional anomalies in more than half of patients with rocker bottom foot. This is in contrast to talipus, in which additional anomalies are noted less commonly, that is approximately 10 to 20%. So whenever rocker bottom foot is identified prenatally, a thorough search for additional anomalies needs to be done. Thank you.
Thank you, Dr. Zora. That was a great presentation. So we come to the end of our talks and the presentations. And now I would like to request Mr. Pragyan Saikia to just give a few comments. He's a consultant genetic counselor of Northeast India. He's a BGCI level 2 genetic counselor with 5 years of experience working at Lifestyle Diagnostics. And he has also worked with Strand Life Sciences in the field of pediatrics, gynecology, fetal medicine, and oncology. And after that, I would like to request our 3 expert faculty to give their comments and have a discussion. Thank you so much. Over to you, Pragyan. You can just...
Thank you, ma'am, for the introduction. So, hello, everyone. I think it's been a very long knowledge gathering session. So I'll just shorten it up. Like most of the things that was need to be spoken was already taken care of. I'll just like to get on to some of the few things which I feel it is necessary from a genetic point of view. So first of all, is the clinical indications that we are talking about here. So polydactylis, whatever the clinical indications that we get from ultrasound, it is very important to get to give that information in terms of the prescription or in writing to the lab where we are going for the testing, because based on those indications, the analysis will be done, and we will the quality of the report that we get will be based on those clinical indications. And most of the times, if we give like, for example, facial dysmorphisms and not providing the accurate radiological findings, it will give us, mostly what I have seen from my experience, it will give more of VUS, which is basically we cannot, which is not much of actionable in terms of prenatal diagnosis and whatever further decision that needs to be taken. And as Gina ma'am, Dr. Mohit sir, and also Dr. Bhutia, Dr. Zohra ma'am, everyone has given their presentations very nicely. And like just for, I have to add a few things, like the split hand foot malformations. We usually see a lot of genetic variations that are deletions or duplications, and less of gene variants. So it is very important to understand the clinical indications and where the differential diagnosis is going towards, and accordingly go for the testing. For example, CMA will give results in terms of microdeletion duplications or copy number variants, and whole exome is more towards genetic variants. And there is also nowadays better test, like for example, it's basically a whole exome sequencing with more specificity towards clinic copy number variants. It has more specificity in catching those copy number variants. So we can also look towards that when we are seeing skeletal dysplasias or limb deformities, where we see both deletion duplication as well as genetic variants to be present. And also to add on to this, there are certain times where the genetic testing has been already done before, and the parents has come for the next pregnancy, and they come with their genetic report. It might be a 4-year-old or a 3-year-old genetic test, and we might encounter, if it's a positive variant with a pathogenic classification, then well and good, then we can do a carrier screening based on the inheritance pattern and everything. But if it is a VUS, so it is very essential to go for a reanalysis of the particular data of the particular fetus or the child. So it will help us to understand if the particular classification, because the classification of the genetic variants like pathogenic or likely pathogenic or VUS will change according to the knowledge that we have based on whatever uh, um, the testing that has been done. Basically, all the research that has been done. So it is very important to go for a reanalysis of those VUSs before going for a further testing. If the particular variant is upgraded or not, we will have that understanding, and based on that understanding, we can suggest the particular genetic testing to the parents. If for example, if a VUS is upgraded to a likely pathogenic or a pathogenic variant, then it is evident that we need to go for a invasive testing in the further pregnancy. And if it is the same VUS, we are not, it is not actionable in terms of going for a termination or not, but we can have the discussion based on the pros and cons with the particular parent, and accordingly we can take the decision. So I think that is all I have to add. There are so many things that was discussed very nicely, and I'm very honored to be part of this virtual stage. And thank you, Gina ma'am, for inviting me here. Thank you so much.
Thank you, Pragyan. And now I would request our teachers, Ashok Khurana sir, Bimal Sahani sir, and Dr. Mohit Shah, to kindly give your comments and enlighten us further.
Excellent presentations, all three of them. Really good. Well, the good thing is that they've taken the images well, stored the images well, and they presented quite nicely. So we are glad to see the enthusiasm coming from the far corners of the country. Great.
It was fabulous. I think right from the beginning, every the way you brought up, Gina, the very important point, and I think I was very happy that sir actually made you speak on this, why we miss abnormalities, and I think you took us in a very nice way on what is the world literature, what does it say, and how best can we avoid that. The only thing I would say is that we need to give equal importance to the extremities. Then, what we give to the heart and the brain. The fetus is prone, you will probably wait for the fetus to become supine to look at an apical four-chamber view. But people don't do the same for extremities. And especially in the Indian scenario, if you look at all the consumer cases, majority of them actually are because of a missed limb. And hence, I think every time that you do a scan, it is important that you look at the extremities, all four extremities. Just because the one which is closer to the probe and you've seen the femur and the tibia fibula and everything, you feel well. I think it is very, very important that we look at on both the sides. And as rightly pointed out, the best time to look for extremities is in the first trimester. And I think it should be an integral part of your first trimester screening. And of course, skeletal dysplasias is vast, very, very vast. We do end up circumventing it to a very large extent, but I think Mohit also gave us a few very important messages that yes, three important things. Is it a skeletal dysplasia? And whether it's lethal or non-lethal. I think if you can point out this is a skeletal dysplasia, you've done 80% of your job. And if you have said that this is lethal or non-lethal, another 19% is done. The rest of the 1% that we can leave it on the experts to take care of, and the geneticist. And now because everything is molecular, so we can leave it to the geneticist to give us a final diagnosis. Overall, a fabulous, fabulous evening. And I think everyone who has attended has really gained from this. Great work to the complete Northeast team.
Thank you, sir. Khurana sir.
Yes, I fully agree with Bimal. It was really a practical session, and it's going to serve as quite a milestone in our teaching program on YouTube. I want to congratulate the whole team on how well they worked together, including those 4 case presentations where we found that all these lessons were put into practice. Bimal has brought out an extremely important point, which means that protocols exist and we tend not to follow them with the same degree of respect as we would do for the heart and the brain. And that is really one of our major problems. There is no doubt also that we need to create awareness amongst the public that not every ultrasound has a 100% detection rate, and we are working at the center to do so. I think there are a few very important things that still need to be answered, and some of these are in our question box. And with your permission, if I can include that as part of the comments that I wanted to make. The
Yes, sir,
first
please.
one was, thank you. The first one was on Preena Shukla, and she wanted to know if a limb abnormality is isolated, then is this an indication to request, or can we straightforward deny? So the first thing that we will look in this situation is whether this limb abnormality has been discovered before 24 weeks or after 24 weeks. Before 24 weeks, it is the mother's right to request for a termination of pregnancy, irrespective of the seriousness of the abnormality, because that is the mother's prerogative, and we do not argue with that. Beyond 24 weeks, it has to go to the medical board, and the medical board will then decide on the implications of that pregnancy in terms of a disability. So therein lies the difference. Before 34 weeks, maternal choice, if I may use that word, it's not a perfectly correct legal phrase, but it's something you and me understand. And after 34 weeks, it has to be a medical board. So that is the way we can do it. There is no question of denying it. There's no individual who will deny it. A group of people will sit together and then decide. And then there's a question for you, Gina, from Harshini Batula. And she wants to know how to look for mineralization and how to look for stippling.
So mineralization, I think in the skull, it is like we see the structures, internal structures much better if it is hypomineralized. And a stippling is basically, sir, we see these extra epiphyseal centers beyond what is like what we ought to see. Like the femoral epiphysis, it comes around 32 weeks, if I'm not mistaken. And, you know, if we see it earlier, we see it in the coccyx, sir, I think you can guide.
Yeah, premature ossification, actually.
Yes.
Yeah, ossification.
It's always for the proximal femoral epiphysis, even calcaneum, coccyx. And so all this, if there is a premature ossification, that would be there. And for mineralization, just to add on to what Gina said, she's rightly pointed out that actually the part of the, when we normally examine the fetal head in an axial plane, the distal part of the brain is very well visualized, but we don't see the proximal, the part of the brain which is towards the probe, because of artifacts coming from the bone. But once there is hypomineralization, you will see that also very clearly. If you use a little bit of pressure, you will find that there is a compression which is happening on the skull. And of course, if there is significant hypomineralization, especially in hypophosphatasia and all, or chondrogenesis, you may find the spine, when you're looking at the spine right in the first trimester itself, you don't find ossifications there. So I think that answers both the questions there.
Yes, and the word stippling, really, if I may add here, it refers to multiple areas within the epiphysis itself. So the cartilaginous epiphysis or the spinal bodies would actually have multiple foci of ossification, and premature ossification would be just one center. And stippling would be like we find in chondrodysplasia punctata, where you find multiple dots,
Multiple dots, yeah,
within the cartilage. And then there is a question for our geneticists, and Ashish Panchal wants to know whether an isolated clubfoot, unilateral or bilateral, is indication for invasive testing. So we have our genetics representatives here. Are they still with us? If they could take that up. Is
Pragyan? Yeah.
Yeah, I'm here. So, isolated without any other, other findings on the ultrasound, it is not advisable to go for an invasive, but we have to like only if it is only clubfoot, because there are certain times we have seen genetic answer for isolated clubfoots also. So, but I don't think I think we need to have a proper discussion on that to actually go for. I think our Sukrana sir or Dr. Mohit sir will be much better equipped to answer on that part.
Yes, Pragyan, I can understand where this comes from. You know that most people in our part of the world resist new information. And in genetics, we have a complete turnaround of information every 3 to 6 months. So in the late 90s, it was presumed that because ultrasound is not so good, therefore we must do an amniocentesis and a karyotype on skeletal dysplasias. And then we realized that a karyotype is not going to help us very much, and so we stopped doing it. And also that ultrasound evolved, and so we were getting information. And then they said, no, ultrasound is very good, and therefore we do not need to do any further genetic testing for an isolated unilateral or bilateral club foot. And then lo and behold, 2 years ago, we get this excellent article from China. And although I like to take them with a pinch of salt because they do tend to be driven by commercial interest sometimes, but it did reveal the fact that yes, there could be some club feet which will evolve during the rest of the pregnancy, and therefore it's worth investigating those in advance to prognosticate the condition. And secondly, that there are a fair number of conditions that would compromise the quality of life in a skeletal dysplasia associated with club feet, where the club feet is the only manifestation in the mid-trimester scan. So therefore, it's now recommended that we do an exome sequencing, a current understanding, exome sequencing for all bilateral club feet to be offered to the patient. Of course, it's up to the patient on whether they take it up or not. In terms of what they actually do and whether we should only do an exome sequencing or we should carry out a bunch of actual genes, 6 or 7 or 8 or 10 of them, to try and cover up what is to be covered. Typically, the number of genes will not matter because then that is searching for a specific diagnosis, which is not a difficult situation. The difficult situation is no other finding, no thoracic abnormality, no general shortening, and no shortening of the limbs or abnormalities of the spine. So in that situation, definitely an exome sequencing for this particular condition of club feet itself, with a dialogue between the geneticist, the person in the lab, as well as the person who's going to look at the data and then find out the database and find out which is the actual condition. So as of the last few months, I've been actually doing invasive testing for all bilateral club feet. In fact, unilateral as well. And then there are some 2 or 3 very interesting questions that came along, which need short answers, and I'll put these to our experts. And this is from Juhi Chawla. She wants to know if premature ossification of the talus without any other abnormality signifies something. So Mohit has an answer for us.
I think so. Premature. So if you have.
Yeah, no, I haven't come across any indication where premature ossification of the talus as an isolation would need any other indication. And Bimal, what would you think?
No, sir.
Yeah.
Never come across anything on that.
That's right. So we will go beyond that. And then, of course, this very, very specific question. I don't know whether Dr. Dika is still here with us. Is there any particular stage of fetal development wherein a teratogenic exposure has a maximum impact in terms of an abnormality in the fetus, in terms of number of weeks of embryogenesis?
All the teratogenic effect is usually during organogenesis.
Yes.
So we believe that whatever even drug teratogenesis has maximum impact during the 8 to 10 week duration. And how would I put it? It's very difficult to quantify the degree of teratogenicity unless you start seeing maldevelopment effects of the disorder in subsequently. But exposure is maximum during organogenesis. I mean, vulnerability of the fetus.
And so it would be useful to make sure what was the exact date of when the patient was exposed to those medications or that teratogen. Then there is a very interesting question from Dr. Bhavya. She says all the bones are short, no lethality. The mother has a short stature. Can we label it a constitutional dwarfism, a constitutional short individual for sure, or do we need any testing?
How short?
Depends when you find, sorry.
Yeah, the question is how short? If it is, even I would say even up to -3 standard deviation below, and both the parents are short, I I think the the point I want to make is we should always think more towards normality than a pathology. So we shouldn't label skeletal dysplasia that easily. So anytime you find bone shortening, n number of times when the patient gets up from the bed, you realize that the answer is with you. So if it is definitely, you have 4 standard deviation below or more, then it is likely to be pathogenic. But otherwise, both parents short, and there is no bowing of bones. Mineralization is good. The thorax is normal. Uh, you can say that this is more likely to be constitutional, and of course, ask for a follow-up after 3 to 4 weeks and see the trend. If it's still maintaining that centile, then I think you will be more confident on calling it as constitutional.
Excellent.
Presence. If it presents in the second trimester, then we should be worried about aneuploidy. At least we need to exclude that, either an aneuploidy or early onset growth restriction, before we really call it constitutional. And then subsequently, we always have a scope for follow-up. So follow-up is the most important thing. And as Dr. Bimal said, everything is falling into place. You can probably take it as normal.
Generally, all long bones short does not become a marker for aneuploidy as such. When you have all the
long bones, sorry, yeah.
So
I missed that, yeah, I missed that.
If it's an isolated fever or humerus, definitely we'll give more importance to that.
Right. No, I missed that part of the question. Good.
Yes, and then there are 2 questions for Dr. Mohit, all about the same thing. Vijay Kumar Chinnasamy and Aarti Joshi want to know the reference for scapular length. What reference was that?
You have charts on the net. Well, basically, you need to take the sagittal section of the scapula, where we measure it from the tip of the acromion to the inferior border of the scapula. That's considered a scapular length. And then you have nomograms, which are available for free on the net, which you can correspond to.
Excellent. And there's a question from Dipali Sable, and she wants to know if we need to take all bones on both sides in case there is suspicion of a skeletal dysplasia.
Yes, always.
Yeah. And in addition to that, it's a good idea to make sure you've got your head circumference correctly measured, you've got your thoracic circumference also correctly measured, and a very careful look, if necessary, for the angles, for the jaw, etc., to be sure whether there is an associated microretrognathia. So those would be measurements that are required, right side, left side, both ulna, both tibia, and so on. We have had a lot of appreciation for all these talks, and there's a whole bunch of, and I fully understand that. And I think the presentations by our young presenters were really nice, very well worked up. I'm glad someone is able to guide them accordingly. And then there was this question from a therapy point of view from Dr. Varshini. And she said that she's a student of MSc Applied Genetics. And she wants to know how far have we come in terms of regenerative medicine, stem cell transplantation and fetal surgeries as a conduct towards prenatal limb abnormalities. Is there anyone amongst us who has some clues on this?
The only stem cell treatment I have heard from was from the Singapore guy, who had, I think, come to one of our programs, if I'm not mistaken. But I don't think they are still working on skeletal dysplasias per se. At least I'm not aware, sir. Maybe if you are.
I haven't seen anything on this at all, including for the types of osteogenesis imperfecta. It seems like a very good idea, but I don't think anybody has done any work on this so far. Our final question, of course, is from Gaurav Sharma, who wants to know if an isolated short femur length in a third trimester scan with everything else normal, what should be the counseling?
Everything is fine. Just follow it for the growth. If the growth is maintained, if the growth curve is maintained, we shouldn't be worried.
Excellent. And that brings us to the end of this. I really must put in another word of appreciation for the amount of scientific content and its wonderful presentation that our Northeast chapter has put in. And
Yes.
it's really worked out a useful evening. I know we dragged on, but believe me, we need these drag-on sessions for our daily learning. There has to be a different content of our webinars where we learn more easily rather than sitting in a room and rushing through for 20 minutes. And I'm so glad Dr. Gina and Dr. Purva have started putting these webinars together by being sensitive to people's requirements, not only in the Northeast of our country, but also all over the country. I think the questions we face are pretty much similar. All of us have the same clinical problems on a day-to-day basis. And I'm so glad you're putting these together in a very understandable and slow-paced manner. Congratulations.
Thank you, sir. Thank you, sir.
Thank you.
It's your
Yeah.
guidance.
Looking forward to the next one.
We certainly hope we see all of you in Eurocon.
Yeah.
Yes. We still have a few seats left, so if you want to fit in the corners of the room, you have still time to register, and the registration will remain open for another 2 days.
See you then. Good night.
Thank
Good
you
night.
so much. Yes.
Good night, sir.
Good night.
Good
Thank
night.
you, everyone. Good night.
Good night, sir. Good night.